Welcome and thank you all for holding. I would like to inform all parties that your lines are on a listen-only mode until the question and answer segment of today's conference. Also, this call is being recorded. If you have any objections, please disconnect at this time. Thank you. You may proceed.
Good afternoon. Welcome to the third ASTDA CDC STD Division Prevention Science Series Conference for this year, for 2013. It gives me tremendous pleasure to introduce to you Dr. Tom Quinn, who is one of the leaders in our field, as I'm sure you all know. It was quite interesting going through Tom's, not his CV, but what has been written about him when he received the Distinguished Alumnus Award from Notre Dame this year. So Tom did his training at Notre Dame, his bachelor's degree and master's degree. Was actually in graduate school, I found out, was getting a PhD when he was drafted to go to Vietnam, which changed his life plans, and he became an MD instead. He did his medical education at Northwestern University, was later trained in Albany, New York, and University of Washington, Seattle. Currently, he is heading the Global Health program at Johns Hopkins University. He also heads the Global Health program at NIAID, NIH, right? So it's very, I won't have enough time to go through all of the awards he has received because there are too many of them, and he told me not to take much time introducing him because he needs every single minute in the hour for his lectures. I'm not going to talk too long, but he has published, this is really scary to me, over 700 papers. So I don't know what else to say about that. Now, he has received many awards, and he has played a very important role in the scientific field of HIV prevention, prior to which he had played a very big role in scientific field of chlamydia prevention. He is quite important, both epidemiologically speaking and in terms of laboratory issues. I'd always like to introduce some personal aspects introduction as well when I'm introducing one of the speakers here. I don't know too much about Tom personally. What I have observed is I don't think there's anyone who doesn't like Tom a whole lot. He's very likable to everybody. He also says he likes everybody. So I don't know whether there is a social psychological correlation there. I also know, in addition to liking everybody, he adores his daughter and his 3 sons and his wife, Jeannie. Tom?
Thank you very much, Becky. It's a real pleasure to be here. I want to thank you personally and Gail for inviting me to be with you all day today. And it's a real pleasure to be here. Those 700 peer-reviewed articles, I didn't write every one of them. I want to give credit to the people who did, and I just played a minor role in some of those. But it is true, I have a lot packed into this talk, and so I'm going to go fairly quickly. Let me go over the outline of what I want to talk about. There we go, objectives. Going to review, first of all, the current status of the HIV global pandemic and the international response, what that really means. We have an article I wrote with Peter Piot on how AIDS really define global health today. And so we'll talk a little bit about that. But then I go into much more detail in terms of what we have learned from our biomedical research and the biological data on viral transmission, because if we're going to interrupt spread of this disease, you need to know, what is inherent in viral transmission. And then what are the innovative concepts that's led to in designing and implementing the prevention strategies. And then I'd like to discuss the future implications of what everyone talks about as combination prevention strategies to control further spread of HIV/AIDS. So here we are. CDC was the first to describe the original cases. It's 32 years later. And what has happened? We've had 68 million people infected, 34 million people currently living with HIV, and over 34 deaths. One of the worst epidemics of our time that has really redefined infectious diseases in the modern era. This is the HIV pandemic at the end of 2012, some 9 months ago. 34.2 million people living with it. And I've broken up that number into categories. Those that are being treated, 9.7 million, that's on ARVs. PEPFAR and Global Fund fully responsible for 80% of that. It's truly a phenomenal international response to get these people on treatment, most of which are in Africa. 5.5 million clearly need treatment, but are not accessing care for a variety of reasons. Either in developing countries, it's just not available, the money's not there, the drugs aren't there, whatever those definitions might be. But it still leaves 19 million who are infected who aren't even being considered for ARVs until 3 months ago when we changed the case definition for access to care. So now it's at 500 CD4. This is when it was at 350. So this is our current pie. This is where we are. Now, last year, there were 2.5 million new infections that fed into the pie. Out of the pie, there were 1.7 million deaths. So you can do simple mathematics. If that continues for the next 4 years and we don't change it, the pie got bigger. And the numbers within the pie have changed. You now have 15 million people treated, hopefully, but now you got 12 million who need treatment and aren't accessing it, and 23 who still will need ARVs. So it's an untenable situation, and yet the mantra of the day is an AIDS-free generation. But where does that come from when you have those kind of statistics? Well, it comes from the former Secretary of State, Hillary Clinton. It comes from a variety of programs. It comes from our current president, has been talking about an AIDS-free generation. There's all sorts of other definitions. It's the beginning of the end of AIDS. It's the beginning of end of AIDS begins with you. We have a former president, President Clinton, talking about an AIDS-free generation. Multiple places, and it makes the State of the Union address. This is what they're talking about. We're going to reach an AIDS-free generation. But I just gave you all those numbers, and so there's a disconnect. And we're going to talk about that disconnect and how we can try and make it connect. Because I do believe we can attain an AIDS-free generation, but it's going to take enormous resources and enormous support worldwide to be able to do that. The first place we can achieve that is to prevent mother-to-child transmission. That's a success waiting to happen, that we will not have another child born in the world with HIV from a mother because she didn't get care or she didn't get put on treatment. And how did we get there? I mean, we are attaining that in the United States. We're very close to that. And it all came from a series of biological studies that showed that for every log increase in viral load in a pregnant woman, the risk of that virus going to her baby was 2.5-fold. Okay? Very solid biological sense. And you could put it into a very simple schematic. On your left is the mother, then the placenta serves as a blood barrier to the virus most of the time, and then, of course, the fetus. Well, for every increase in viral load that we talked about, we get increased transmission across that blood barrier. If the placenta ruptures early, you get increased risk of transmission. And if the mother breastfeeds after delivery, there's a risk of transmission. It turns out it's due to the level of viral load in the breast milk. It all comes back to viral load. And how did we go about doing interrupting this? Well, we put the mothers on treatment. We put the baby on prophylaxis, PrEP, if you will. And then we continue treatment if the mother wants to breastfeed. And now the guidelines are that they should be continued throughout their life. And if the baby is breastfeeding, the baby should continue PrEP, if you want to call it that, but should stay on treatment. And if there is early duration of rupture of membranes or prolonged rupture, you do a C-section. So we had to prove that, and this is the body of evidence. You know, we all say, okay, observational data is interesting, but we need a randomized trial. You can see it starts in 1994 and goes all the way up to just a few years ago. We've done enough randomized trials. They all show a benefit of antiretroviral drugs in preventing transmission. And so let's look at the public health impact of implementing those kinds of innovative concepts, treat, lower viral load, and continue that through breastfeeding and afterwards. And what you see on this graphic, which comes from this institution, is that the number of babies being born with HIV is less than 50 now. It's less than 25, I think, in the last particular data. So we really have, I wouldn't use the word eradicate, but we're as close to eliminating this as we are with any STD that we've talked about. And this is a huge success story, and this is an AIDS-free generation for the babies being born today in this country. The thing is, we got to expand that to the world. And here are some of the data that just got presented in Kuala Lumpur at the International AIDS Conference. And it shows that had we not done anything, this might have been the graphic, this line here in the green, 500,000 babies being born every year with HIV. But instead, because we have rolled out antiretroviral and we put attention on screening pregnant women, we're down to about 350,000. Well, you know, that's a decline of 150,000 per year. That's pretty phenomenal in just a couple years, but it should be much better than that, let's face it. So where is the problem? Where is that disconnect we're talking about? It's rollout. Here it is. Look at East and Southeast Asia. Only 19% of pregnant women are getting antiretroviral drugs during their pregnancy. Look at North Africa and the Middle East, 6%. This is a disaster. I just went to a meeting in the Bahamas just a month ago, and I have to say, they're very proud that they're at about 80% rollout. And I can tell you in the last 3 years, it's not been a baby born in Barbados who's gotten HIV infection, and they're very proud that they've been able to create an AIDS-free generation for the babies being born in that particular country, island. So there are successes, but there's a disconnect, and we are going to have to work as a global society, this is my global health hat on now, to make a difference in these other countries. Why is that rollout so bad in those particular areas? Because this is where our success should be. UNAIDS would love to have 2015 or 2016 to have 0 babies being born. We're not going to make it, but it's good to have that goal, and we will achieve it in the years to come. So I do want to give credit to our political leaders who believe in an AIDS-free generation, and we need to look at our successes and build upon those and address the challenges. Now, we're going to turn a page, go from perinatal transmission to sexual transmission. This is a tough one. And I got involved because I had been doing a lot of that viral load work in the pregnant women, and I started to apply it to discordant couples. And when we talk about sexual transmission, we all look at the simple mathematics of transmission of any STD, because I consider HIV sexually transmitted just another STD, and that the reproductive rate is equal to beta CD. What are those things? Beta is the efficiency of transmission. That's related back to the infectiousness of the pathogen or the viral load, but also whether there's cofactors involved. C is the number of sexual contacts. With pregnancy, you didn't have to worry about that. It's mother, baby, mother, fetus. That's all you're talking about. But with sexual transmission, there could be one partner, it could be 5 partners. So C is variable depending on the partnership and the frequency in which they're having sex. And then, of course, there's the duration of infectiousness. So normally, untreated, that would be 10 years because that's the natural history of HIV. But now with treatment and intermittent taking drugs or not taking drugs, that's also variable. But the most important parameter was just the same identical biological fact as it was with perinatal transmission. For every log increase in the index person, the risk of transmission to the partner went up 2.5. It's identical. There was really no difference, and I was amazed at that. But what I think everyone got excited about when we did this study, and I presented this here in a previous presentation, is that if the viral load was less than, in this particular discordant couple study, was less than 1,400 copies, there was no transmission over a period of 3 years. All right, that's in discordant couples living in a very rural area where STD rates are low. That could vary if you have a high rate of STDs. And so most people say if it's undetectable, then the risk is almost nil for transmission. And the Swiss mandate was you don't need to even worry about condoms, wearing condoms if you're undetectable. Now that became a hotly debated issue because genital viral load doesn't always directly correlate with plasma viral load, which is what I was measuring, but there is a strong relationship, and you could debate it, but I will always promote condom use for a variety of reasons, not just the viral load, but also because of other STDs and other risks that might be involved. But what does it all calculate out to? This is a virus that's pretty inefficient in transmission. Taking all the studies, the average is 1 to 2 transmissions per 1,000 coital acts. That's really pretty inefficient. Hepatitis B is much more efficient than that bailiwick. So would gonorrhea, chlamydia, and the other STDs. So it's pretty inefficient. But that changes if there are cofactors. So what's the genital viral load? It could be independent. There could be compartmentalization. It could increase if there's inflammation. Is this acute HIV where there's no immune suppression of the virus yet, and the viral load is 2 million copies? Is the person immunosuppressed, has no immune surveillance on the virus? What about presence of genital ulceration? We know herpes increases that risk of transmission at least 2 or 3-fold. And if it's an acute HIV with a 2 million copy viral load and they have herpes and they're uncircumcised, it all adds up. It gets to be higher and higher risk. And I could go down each of these. We could have a whole talk on each of these, but I won't bore you with that. We could talk about it in the discussion. But then there's the partner. And the partner's risk of getting an infection isn't just 1 out of 2,000 coital episodes. It depends whether that person has an active sexually transmitted infection, whether they have cervical ectopy, whether they're uncircumcised, whether they have delta 32 CCR5 genetics, which would make them more resistant, or what is their innate immunity? Are there issues of adaptive immunity that might be discussed, such as frequent partners of commercial sex workers, or even immune activation, which could increase susceptibility. Let me just give one example because I got very excited in our early studies on the viral load to see, well, do STDs serve as cofactors? And this looks at the viral load of the infected person and the risk of probability or risk of acquiring it per 10,000 coital sex acts. And if the individual is undetectable, even if the individual has a genital ulcer, the risk is still fairly negligible. It's not zero, but it's very low. But once you go to detectable viral loads, there is a significant difference in the individual who has the genital ulcer versus one who doesn't in terms of their probability of transmitting the virus to the individual. And this led to the 032, I think it was called the acyclovir trial, that because most of these ulcers are due to herpes, to see if it would decrease transmission. And unfortunately, either because of the dose we chose, but with Connie Kellum and others, or the duration or the adherence, we didn't see a significant effect. But that's now history in terms of that. But clearly, it will impact transmissibility. Now, the viral load studies and getting undetectable led to this whole body of literature called treatment as prevention, even before 052 came out. So lots of observational ecological studies. This one I wanted to show you was led by Steve Reynolds. And it was in Rakai where we had done that discordant couple study. So we looked at 250 HIV discordant couples. We used the country guidelines as to who got put on treatment and who didn't. And we followed those individuals to see if there was any transmission. They were all counseled. They all got condoms. They all got off of circumcision, et cetera, et cetera, et cetera. Bottom line is there were 42 transmissions in this particular study, 218 couples who were not on ART for that follow-up period of a 459-person years of observation. That incidence is 9.2. That's a really high incidence, as you can imagine. But that's living and having sexual relations with an HIV-infected person who yet hadn't been put on antiretroviral drugs. For those who got put on antiretroviral drugs, and we followed their partners, we have yet, and this study I capped at 2009, but I'll take it forward now to 2012. We don't have a transmission event yet. If the index person is on ART, we have no transmission, just like mother-to-child transmission. So you can see why people get excited about treatment as prevention. I mean, these are phenomenal data. You know, when you have, zero transmissions, you're over 90% efficacy for sure. And I will say in Rakai, we've had no perinatal transmission. So we're like Barbados. We've not seen a transmission. So can we actively say we're getting near an AIDS-free generation? I actually think we can say that. We have a ways to go, but it does give us hope that that will go forward. Then Connie Kellum's study was interesting. That was the herpes trial that I just described. But she also, if they were HIV infected and they met country guidelines, they got put on treatment as well. But if they didn't meet country guidelines, they were followed, okay? And here are her data. Deborah Donald reported this. And you can see there were 103 seroconversions, and all of this is the mother of all discordant studies, 3,381, fairly phenomenal. But this is not a randomized trial per se. This is observational because it was a herpes trial that this was embedded in. But overall, 92% reduction in HIV. So we're greater than 90%. She's finding greater than 92%. All of this leading to a randomized trial. And Mike Cohen says I was always his biggest critic of the 052 trial. And the reason I was a critic of it is because of all those observational data were very supportive. I'm going, why are we still doing this trial? We know it works. I'm actually glad he persisted. I could never convince Mike Cohen to change his mind on anything. And he did this trial. We're going to look at two aspects. But the first aspect of this trial, which is very important, made, scientific breakthrough of the year in 2011 was that in randomizing people to antiretroviral drugs or not in the index partner, there were 28 linked HIV transmissions. And we'll come back to this linkage issue with the molecular methodology that I'll talk about. But there were 28 of them, one of which was in the treatment arm. The other 27 were in the wait arm. People hadn't met country guidelines for treatment yet. That works out to a 96% efficacy rate. So this was heralded as really one of the biggest biomedical studies in the field of HIV. HIV is the outcome, transmission. It works because you're lowering viral load due to the antiretroviral drugs, and the people are protected from getting infected. So, again, great study, and it occurred at the same time that we're scaling up antiretroviral drugs through PEPFAR and Global Fund, what we were talking about before. So we have essentially 10 million people on treatment right now. It was 9.7 in my little pie. I'm going to add 300,000. Let's just round it off. Just call it 10 million. By 2015, 2 years from now, a year and a half from now, we're supposed to be at 15 million. I actually think we'll get there. But look at where most of this is occurring. It's occurring in sub-Saharan Africa, where the biggest burden of the disease is. And they are actively seeing declines in incidence in some of the populations where this is being rolled out. So this is all coming together, all at the same time. And I think for anyone who's interested in this field, this particular study that I'm showing you from Tanzer and colleagues from the South African Center in Republic of South Africa, KwaZulu Natal, shows that for every 10% increase in coverage, there's a 17% decline in individual risk of acquiring HIV. So incidence is going down as you roll out antiretroviral drugs, and they get to greater than 40%. Now, the models all say we got to get to over 70% coverage if we're really going to attain a decline in the reproductive rate of HIV. So we have a ways to go. But the benefit here is decreased acquisition, decrease in the incident rate, and even better, increase in life survival for the people who are being treated. And I've never, in my history of medicine, and I've been at this for 30 years, I've not seen an intervention that has added 10 years of life survival to a population the way this has. Yes, I know vaccines do that, but this is in adults who are getting treated. This is pretty phenomenal. And so there's dual benefits for the infected person and for the uninfected person. And the overall impact, as I showed for the babies, I'll show for survival of adults. We've prevented 4.2 million deaths in just the last 4 years, 5 years. This is truly remarkable, and again, it's what Peter Piot and I tried to bring out in our paper, that it was the international response to a major epidemic that turned the table and enables us to talk about an AIDS-free generation. And so I think, again, I'm very positive about this, that this is really moving forward. But we're going to have to recognize what the challenges are. And you saw for the mother-to-child transmission, it was rollout of ART to pregnant women in certain areas of the world. For sexual transmission, it's even more complicated because of all those cofactors, because of the behavior that's involved, and cost, supply. So WHO, having seen all these data, obviously, and being a part of it, actually changed the treatment guidelines. The U.S. changed them a year earlier. We basically say if you find an HIV-positive person, you're supposed to offer them treatment. Hopefully they'll be ready for it, but you are to do it. In WHO guidelines, they say less than 500. You remember it used to be less than 200, then it was 350. Now it's less than 500. And if they're in a discordant partnership, they should be offered it. Viral load testing should be done because what you're looking for is undetectable viral load. That's what treatment as prevention really is required. And they're trying to simplify the treatment and get rid of the toxic drugs that are out there. So that's the summary of all the positives, okay? The great news, we could stop the talk right now, and we'd all be very positive and happy about what we've been able to accomplish. But that's not the story. The story is that there's a lot more that needs to be done, and I want to spend the second half of the talk actually talking about those challenges and why an AIDS regeneration may not be as easily achievable when we bring in sexual transmission. So it's sort of my glass half full, half empty. You heard the half full, now we go to the half empty. And the first is the cascade. So treatment as prevention means everyone's on treatment and you've got everyone virally suppressed. This is from our paper that just came out in New England Journal in May. And the U.S. data, you know, Gardner and Hall both individually showed that this is diagnosis of HIV infection. And I compare another country, Mozambique, to the U.S. If you think the U.S. is in bad straits because we only have 28% of our infected population being virally suppressed and non-infectious, in Mozambique, it's about 10%. So if we really are going to achieve, viral suppression and decrease transmission, we have to work on the cascade. So that's the challenge. Now, what's the solution? Let me give you a couple success stories here. These were the recommendations when we saw the guidelines. This is in the MMWR and other places. We need to expand, simplify, and diversify HIV testing. The guidelines came out, everyone from 15 to 65 should be tested annually. Well, at least get tested, and if you're in a higher risk population, at least annually. Offer concrete interventions in the pre-ART window before they hit that 500 or whatever. Use simple, better drugs, and WHO has adopted that. Provide diagnostic tests that are simple and are point of care. So every emergency room should be able to test immediately. Innovate service delivery, enhance adherence and retention. So it's changing the cascade. That's what that's all about. Two examples. Let's go to British Columbia. So they looked at their cascade in 1996. 53% of their HIV population had a diagnosis of HIV. The other were unaware that they were infected. Then linked to care dropped to 43%. Those retained in care, less than 30%. Prescribed ART, less than 20%. They only had 2% of their population virally suppressed. Now, that's 1996. We're talking a long time ago. So now they revisited it in 2009. This is for all HIV-infected people in British Columbia, where they have a good census for this. 86% are aware of their infection from the studies they've been able to achieve. They're at 79% linked into care, 55% retained in care, 46% prescribed ART, and 32% virally suppressed. So you still might say, well, I'm still not at that 60, 70% mark, but we're making a change, and it's little baby steps. And we have to keep working at this. Here is King County, Seattle. And this is, it's compared to the U.S. data that had been previously published. And they decided to work on, can we improve linkage to care in King County? And you can see they didn't drop down to 66% like the rest of the nation. They were up to 78% being linked into care. They then said, let's keep them in care. and they're at 71%. So they put all their energies in here, and if you put the energies here, usually the follow-through is much better, and they're at 57% of their HIV population in their census being virally suppressed. And that's getting closer to the 60 to 76%. So challenge is the treatment cascade and getting people to be virally suppressed and staying on drugs and so forth. And the solution is working in these particular arenas. So that's one aspect of how we try to get more and more viral suppression. Now, I want to skip away from treatment as prevention for a couple minutes because it's another area I got excited about, and that's circumcision. This is more pertinent in Africa, but in other places where there's heterosexual transmission, female-to-male transmissions, where this really applies. This is not as pertinent to men who have sex with men, which is still a big driving factor of our epidemic. But let's say, well, how did we get into circumcision of men as a means to prevent HIV transmission? So it goes back to the original viral load study, and when we published this study, and the New England Journal, you're all very happy that, hey, it made one of the premier journals, and you're excited, and it was all about viral load. I actually didn't find that interesting. I actually thought inside that paper, one paragraph describes these data. We've subsequently expanded it and published it in another journal. But I actually thought this was fascinating because look at the data. This is female-to-male transmission in those discordant couples where the female's the infected index, and you can see her probability of transmitting to her male partner goes with the viral load. It actually pops off after you get to 20,000 copies. But if the male partner was circumcised, then none of them got infected independent of viral load. It broke the biological barrier of viral load predicting transmission. So, I had to put it in there that viral load is the most important biological transmitter unless you're a circumcised man. Then it's not. And I found that absolutely fascinating. It led to 3 randomized trials, plus all the other observational studies, and all of them showed a 50 to 60% protection. If we had a vaccine that showed that same type of efficacy, that we'd be stopping the AIDS epidemic. But we found it in male circumcision. It's done one single time in the person's life. One time. It's not dependent on adherence. And sure, sexual behavior will modify that to some degree. But look at these data. This is now community effectiveness. If you're circumcised, this is your acquisition rate in Rakai, in Uganda. And if you remained uncircumcised, I didn't want to get circumcised, I'm too busy, I don't want to have that surgery, whatever reason it was, works out to a 73% community effectiveness. And you might say, yeah, that's Rakai. They're so unique. Well, here's Kenya. Just over the border, they did one of those randomized trials. They then follow the people afterwards, offered circumcision to everyone, same reason. Look at the difference in the 6-year incidence. Circumcised 4.8, uncircumcised 11.0. So we're at that 63, 64% protective effect. Truly, I think it's absolutely, truly remarkable that a single intervention that takes 15 minutes can afford a man that type of protection. And you might say, well, what about the woman? How is she getting protected? Well, if the man doesn't get infected, then hopefully he's not going to transmit this type of virus to the female. Well, Aaron Tabayan in our group and I decided to look at the body of literature from randomized trials. This shows the efficacy rate from the 3 randomized trials for HIV. So they're all showing a 60% protective effect. Here's your efficacy. If it's over 1, it's non-efficacious. Well, If we look at high-risk HPV, we actually reduced that by 30% in the men. What about herpes? Out of the 3 trials, 2 of them, well, at least one, and the confidence interval crossed one here, but also showed a significant effect. Genital ulcer disease, 50% reduction, and no effect on gonorrhea, chlamydia, trichomonas, the urethral pathogens, and you wouldn't expect an effect on that. But what about their sex partners? So we looked at the female partners in our Ugandan study. These are the reductions of acquisition in high-risk HPV in unvaccinated women. They don't have the vaccine in Uganda. And you can see it's 30%. Bacterial vaginosis is 40%. Trichomonas reduction, which is pretty interesting, showing a 50% reduction in genital ulcer disease, a 20% reduction in that, all 4 statistically significant. So there's public health benefit in both cases. And, you know, that's the reductions in STDs, which are serving as cofactors for HIV. And it also, we looked at its biological aspect. By removing the foreskin, we're removing a number of cofactors for HIV. One's the dendritic cells, the cells of primary attachment of HIV when it enters, and then, of course, CD4 and CD8 cells in people who were herpes virologically positive. So there's biological benefit as well as from both the STDs as well as removing the susceptible cells in the foreskin. So the goal was set by UNAIDS to need to circumcise 20 million men in Africa and anywhere else where you might see heterosexual transmission. Where are we to, you know, at the end of 2011 was 1.5 million. So, you know, it's just like perinatal transmission, just not rolling it out as effectively as we should. So here we have a solution, but we don't. The challenge that I don't have a solution to is how to convince more people to take this up and get circumcised. So the last part of this talk is really to come back to PrEP, pre-exposure profile. How do we protect the uninfected individuals, the susceptible ones? And for men who have sex with men, was the IPREX study showed 42% efficacy with taking Truvada on a daily basis, once a day. There was the Partners PrEP trial, 75% efficacy in discordant couples. And the Truvada study, which was done in Botswana, both men and women, 62% effect. So we were all jumping up and down saying, okay, we treat the infected people, we offer PrEP to the high-risk, highly exposed individuals, we got a winning scenario. And then came along FemPrep and Void, and they didn't work. They were stopped. Now, what happened? Turns out they didn't take the drug. If you did blood levels in the individuals who were randomized to active ingredient, you found only 26% of the FemPrep women were taking it, and in the Void, it was only 20%. And of course, you're not going to get efficacy when you're below a threshold of 40 to 50% adherence. If you have higher adherence, and the one who really leads the farm on this is Connie Kellum, 81%. I don't know what she did to get people to take their drugs so religiously, but they took it, and they get a very high protection, 75%, better than circumcision in that scenario. So it really does work if you take the drug. Now, some of you might have gone to the Kuala Lumpur International AIDS Conference. They presented the injecting drug use PrEP. So if you're an injecting drug user at risk for HIV and you take PrEP, you're protected, and that protection varies by adherence. So the higher the adherence, the better the efficacy. So what are we talking about? What's the common denominator here? Biomedical intervention, behavioral aspect. And if you're, we've been dealing with behavioral aspects of this epidemic for 30 years We didn't win on just behavior alone, so we added the biomedical. We can win on biomedical, but not without behavioral interventions, the way I'd like to pitch it. You've got to have both hand in hand or it's just not going to work. So what do we do to help adherence? Let's give something that's inserted and it lasts a whole month, and that's the Parathene ring that's being tested. There are some concerns about that trial right now, and I won't go into it, but we'll have to wait and see what the results show. The concern I have is whether they keep the ring in for the whole month. It's another story. So where are some of the other obstacles to that cascade or the transmission? Where should we intervene? And I want to point out, again, this was from our viral load study, and Maria Wayward focused in on this, that it's during the acute phase of an infection, the first year of infection, that anywhere from 40 to 50% of all transmissions occur. And what we do know is of those undiagnosed individuals that we always talk about in all the studies, people who are unaware that they're HIV infected, the highest rate is during the first year. It's like 80% of people don't know they're infected, and because they just became infected, and it was a non-specific kind of syndrome. Then, and transmission is clearly the highest during the first few months, during you're going through the acute phase. And the risk really drops off. Again, look at this as transmission events per 1,000 coital acts. And then as they become immunosuppressed with AIDS, it starts to go back up again. So what is the solution here? If that's a problem, what's the solution? Increase your screening and use fourth-generation assays. And that is what CDC is now recommending. Screen for antigen in these people who might be antibody negative. So we use assays that are dually reactive for either the antigen or antibody, and it narrows that window. And you have to have a high index of suspicion. Now, I won't go into this in any detail, especially because of time, but another area is vaccine research. And the tough part about vaccine is that an individual who's infected has this big viral swarm. It looks like only one particular strain is getting across the mucosal barrier. And then it takes off and starts to diverge. If we want to succeed with the vaccine, we have to know what's going on right here in that bottleneck that was preventing all these other viral strains and only allowing the one to go through. And one of the common receptors that people are talking about is an alpha-4 beta-7 one. The virus that gets across is not glycosylated, but once it gets across, it then glycosylates immediately. And is there a reservoir of these non-glycosylated viruses that are adept at transmission? And we've been trying to look at that. I don't have all the time to go into the detail, but it does appear that it's archived and that a particular variant of the virus is adapted to enhance transmission. And we need to really define that more and more for our research aspect. This is the glycosylation, and Andy Redd in my lab has been leading this work. And it's quite fascinating in how it interfaces with neutralizing antibodies. So we are excited about development of a vaccine. There's a summit going on at NIH today that I'm missing. And they're talking about what they should do about adenovirus vectored HIV vaccines because the last few have failed. It looks like it enhances transmission, but I'll wait for the summit to come out with that information. But we've been starting to look at, well, what does protect a person against getting reinfected or super infected? Whatever term you want to use. Super doesn't mean that it's a super virus. It just means you're getting another virus. So it's dual infection in the sense that occurring over time. And how does that work? This is a simplistic scenario that Andy Redd and I put together to follow it. So here's my little schematic. So you got this woman, she's uninfected. The man he transmits his virus to her, right? But she happens to have sex with another man who has a different virus, and she becomes what we call super infected. So now she has two strains of the virus. Now, if she has a third partner, she could transmit the original strain that she first got infected with, or the super infecting strain, or a recombinant. And we really don't know which is occurring. We're following this and trying to determine it. But the fact is, superinfection, or the acquisition of another infection in an infected person, appears to be a common phenomenon, and it may be associated with a change in increased infectiousness. Now, if they're on antiretroviral drugs, that could serve as prep against getting reinfected, as well as treating the original virus. So it gives credence to why everyone should be treated and virally suppressed. How do we determine superinfection? This is an example from our review piece, and in the red is the initial swarm of the virus in an individual. We then follow that person 2 years later, and here is the virus 2 years later. It's part of the same swarm. That's not superinfection. That's the normal evolution of the virus. Unfortunately, this particular individual had this infection as well. So here's their primary infection and its normal evolution, but here is the acquisition of another infection. And when we look at that person's viral load during the initial infection, for acute infection, you get a very high viral load associated with transmission. In superinfection, that individual also got a big boost in viral load, again, looking like but not as bad as acute infection. And so through serosorting, where a positive man has sex with another positive man, they run the risk of getting superinfected, which could increase their transmission to an uninfected person or acquisition of a resistant strain to the antiretroviral drug. So that's something we have to be concerned about. Julie Overbaugh has been looking at this as well. Her paper just came out in PLOS Pathogens. These are the primary infections, and then in the red is the superinfection, and when they occurred relative to the infection in the individual. So you can see they're sort of all over the place, but by and large, the majority are within the first 2 years. But there are some that are getting superinfected 4 years out, 5 years out, and so forth. Now, the last part of my talk is how did I put out networks there in my title. So now, in my limited time, we get into the networks, because Stephanie's probably disappointed. But this comes back to 052. You remember 96% protection, great data, and that's based on the linkage, just like I was showing you for those superinfections. But there were 9 unlinked individuals who got infected, all right? A portion of those are actually in the treatment. They were partners of people on treatment, but they went outside of the relationship and got infected by someone else. How do I know that? Because we did the genetic linkage data, just like we do with the superinfection. So I is index and P is partner. And you can see in this bootstrap, they're identical. We know that person transmitted to the other person. But look at this couple. So here is the index. This is their virus when we do a bootstrapping on it. And here's their partner. They're not related at all. And if we do their, the sequencing as I showed you before, there is a significant difference. In fact, this person looks like they got super infected. Not only did they get infected from an outside partner, but then they went back to the original partnership where the person's infected and got infected with that virus, and they ended up with both viruses. Obviously, that's going to accelerate their disease process. So We know people go outside a relationship. So that 96% protection is not intent to treat protection. That would have included the unlinked people. It was built into the protocol that they would only focus on the linked ones, and that's why they get 96%. But it's more like 70%. And in fact, this study that was published recently in Lancet is basically estimating the number of people in cohabitating couples who are having outside of the couple sexual intercourse and at risk. And it doesn't matter whether you're a man or a female, it's frequent in certain settings. And this is by country, some showing higher rates than others. So Kate Grabowski and our group came to Uganda and basically thought we had been doing all this sequence work. And so she said, let's take the diaries of who's having sex with who, because we keep those diaries, and let's also sequence the virus that those people acquire within a 1-year time period. This is an enormous amount of work. I can't tell you, these are PhD papers. This is just incredible. This is the sequence, and what you can't tell is like these 2 dots here, these people are linked. But there are others where they're unlinked. Clearly, they acquired the virus outside of their partnership. So what did she find? She basically found that individuals within a household are at highest risk of acquiring HIV if they live in a household with an HIV-infected person. Big surprise. It's a discordant partnership. So very high rates. In fact, they make up 39% of all incident cases are occurring directly in the household. But where did that other person get the viral infection? So we looked at that. Well, we did all the sequencing. We can't find sources in 20% of those. But the other 40% are from outside of the household contacts, and 62% are even outside of the community. So if I go into the community and do treatment as prevention, do these combination preventions, but I ignore the other communities, the contamination, if you want to use that word, we don't like that word, but people are going to be introducing virus from outside, and it's going to dilute the efficacy or effectiveness of what I'm trying to do within the community. So that's the take-home message of this is that there's significant amount of viral introduction. So we wanted to know, where is it coming from? So we did do some surveillance in the district, and it turns out this is a fishing village, Castanceros, 40% prevalence of HIV in these fishermen, and they're highly migratory. When they're not out fishing, they're traveling through the district, and they're having sex, and they're transmitting the virus. So to complete all this, to bring it full circle, we do need to do combined interventions if we're going to solve this problem of the AIDS epidemic. This is your sort of menu of interventions that you can deal with. But I have to say that as you combine those, if you follow the modelers and you put in very stringent criteria, you actually can get the reproductive rate to go less than 1. But it's going to take an enormous effort. And this is just combining each of those interventions on this particular graphic. And when you do that, you really, this is in South Africa, you can really, by 2023, you'll get to an AIDS-free generation if all the parameters fit in there. But there are certain things that are stopping us from even doing that. And we've talked about the outside concurrent relationships outside of the partnership. The other is that cascade effect and FTD. And this is the UK, just looking at MSM. Their cascade is they've got 53% of all their known HIV-infected men who have sex with men on virally suppressed. That's really good. But the incidence is still climbing. Here's the incidence in men who have sex with men. It's still going up. It's not going down, yet we've got over 50% virally suppressed. What's going on? Well, it turns out they're saying 62% of the undiagnosed people are infectious. Their viral load's greater than 50,000 and are transmitters because they're that other 45% not in the treatment realm, and that 30 to 60% of these are due to the primary infection that's occurring in the very early first year episode. So it's not just getting people that are known to be infected to be virally suppressed, it's getting all the unknowns to get known to get treated. So that's one scenario. Then, this is British Columbia. This is looking at syphilis rates in men who have sex with men, and you can see it was relatively low, and then something happened in 2004 and 5 as treatments being rolled out in British Columbia. Look at syphilis. They have a major syphilis epidemic going on in British Columbia, which, you know, they get good care there. The states are provided, province provided. So that's a problem, but, you know, that's Canada. We don't have to worry about that in the United States, right? Last photo of data, I think this is the last one. This is from Matt Golden. This is phenomenal. I cannot believe these data. They're real. In the yellow is the rate of syphilis, the frequency of syphilis in an HIV negative man who has sex with another man. Shown in the red is syphilis in HIV-infected men who have sex with men. It's the highest that they have ever seen. 4% of all HIV-infected MSM have been diagnosed with early syphilis in the most recent year. This is 17 times higher than in the HIV. What is going on? They are not changing behavior. They got infected due to one behavior, and now they're getting syphilis and other issues. And if you think about the superinfection and serosorting and syphilis, and you start putting that all in a crystal ball, you'll say, we're not going to get to a AIDS regeneration when you've got these type of data showing. So we're going to have to do something different. So I wanted to just show this. It comes from here, actually. Kevin Fenton, I think, prepared this graphic, and I borrowed it from prevention with positive, preventions with negative, and who cares about HIV status? You got to do all of it. And so it breaks it out, but you can see STD screening and treatment shows up. I think he should have put it down here as well. For some reason, whoever helped him make this slide didn't put it in there. I picked up on that, and I thought, well, I can't change his slide, so this is Kevin. But I think he hits all the high points on that, and I really support what he's saying. So let me conclude, and I apologize for going a couple minutes over. Global progress on the scaling up of art, extraordinary. One of the greatest successes in global health today. And I think we will hit our target. Further scale up has to address disparities and inequities. That's in specific countries and key populations. And we pointed that out. Those countries and this country have to face strategic choices and should take advantage of these new opportunities. Big debate. Should PrEP be rolled out? I can tell you, we talked about it this morning. In Uganda, where PrEP prevented by 100% acquisition in susceptible people who were in a randomized trial, is not allowed in the country by order of the president. You know, it's a disconnect if I ever heard of one. You do a trial in the study, and then the president says, I don't want it happening, because he thinks it's going to increase risk behavior. You know, we could debate that. I can tell you it hasn't with the male circumcision. Their risk behavior has not increased because they got circumcised. Finally, antiretroviral drugs for treatment and prevention are by far our most powerful tool towards getting to that AIDS-free generation, but only if adherence to medication and behavioral change, coming back to the syphilis and gonorrhea rates and other things, is equally emphasized. So it's You know, it used to be treatment versus prevention. Remember that there was this debate, should we put our money into treatment, should we put it into prevention? That's all gone because we all know treatment serves as prevention. Where the debate is now is should it be biomedical versus behavioral? And I'm actually saying, no, look, we combined the other two. We need to combine these if we're going to succeed. So, as Betsy said, all of this body of work is not due to me. I'm just the voice of it. I know you didn't say that. You were saying I had all these publications. It's these people who have really done all the work. I can't name them all because of time, but I give them great thanks for their work. And there's a mini group within that slide that unfortunately have to work with me, and they're shown on this graphic. We went out to lunch this summer, and they do the lion's share of all of the sequencing and hard work in development of new assays and so forth. So I thank them, and I thank you for your attention and staying a couple minutes over. Thanks.
Hello, operator?
Yes.
Can you open up the phone lines, please?
Yes, thank you. If you would like to ask a question, please press star 1, and you will be prompted to record your first and last name. Please unmute your phone when recording your name, and to withdraw your question, press star 2. One moment, please.
Hi, Phil Peters, Division of HIV/AIDS Prevention. Great talk. Just on one very narrow issue, what are your thoughts on acute HIV infection and treating acute HIV infection? Is that something that CDC should be trying to push more?
Yes. Yeah, absolutely. I think everyone heard that question. I actually think the sooner they get put on treatment, the lower the reservoir that may get established. You know, that there's some debate, but there's some data to support that. And I actually think the less, we know they're more infectious during that phase. So if you get them treated and get them undetectable within 2 weeks of their acute episode or 1 month within that episode, you may have prevented who knows how many subsequent transmission events while waiting to put them on treatment. I actually feel there's, as long as the individual's ready, you know, convinced that this is going to be beneficial to them and to their partners, they should be put on treatment. And I think CDC should promote that vigorously.
Hi, Tom.
Hi.
That was phenomenal. Great review. One of the questions that I have for you is, do you think that we should separate out the two epidemics, and MSM and heterosexual? You kind of combine them together. And thinking about the issues that are going on with STDs, especially with syphilis, and we're seeing gonorrhea rates increase, do you think that we need to do something different in terms of MSM, in terms of the approach, versus what, as you're combining everything together and make a global perspective?
Yeah.
The question is, do we need to carve out the differences between the two as we continue to see changes over time?
Obviously, 100% yes as well. That I do think we need to separate it out. We need to do targeted prevention. The MSM epidemic is the driving force of this epidemic today. If I look at the data, they're still up there. It's almost like when I started in this. I'd like to get Jim Kern's comments on this someday, because when I first started, it was 1981, and it was all in MSM, and then we saw it in heroin addicts and Haitians and hemophiliacs, and it's how I got involved in this study. Now, and then it started taking off in heterosexuals, and that's its major force in Africa is the heterosexual epidemic. But even in Africa, you've got these pockets of high transmissions among men who have sex with men. It's happening in Europe. I just came back from Asia. It's a big issue in Asia. And now in the U.S., we're seeing the syphilis epidemic, anal rectal gonorrhea skyrocketing. We've got to do something different. And I was asked by Tom Peterman, what should we do different? And I don't have an answer. We need to do something different, and I think we need to have a consensus of experts in this field as to how we go about doing this. What I would like to see is AIDS activists who really made a difference in this epidemic starting to take charge of this epidemic again. It is the population of multiple partners among certain, not all, MSMs that's driving this, and they, in this country and in some other countries, and I think they need to take charge of their community and really help us, help them, and we need to work together. Exactly how that's done? One way would be PrEP. That maybe we should be promoting PrEP more aggressively, and it should be supported publicly. You know, the government could do that. That would be one way the government can do it. And then through discussions with the activists, make sure that that's taken up. That was, I think we talked about that this morning. PrEP is not being utilized to its fullest extent in these targeted populations. You probably have your own opinions about it. But
well, I think one of the things that going to the meetings, and one of the things from the ID community, is going to the meetings and seeing that the lectures on STDs and HIV are separate. And, I mean, that's just one example of there's not this interplay that there needs to be. The STD people need to be with the HIV. Some of us cross-mingle, but the problem is even setting up sessions, it sends the wrong message.
Yeah.
That they're different. HIV is different than STD. And I think you're right. You know, HIV is an STD. And the parties need to come together, not only in societies, but even at CDC. I mean, we need to all come together and have joint meetings together.
Yeah. You'll get no disagreement from me on that. And I have said that for 30 years, that it is an STD. And separating them makes no logical sense from my perspective. Are there any questions from the people on the webinar?
I do have a question from Margie. Your line is open.
Hi, good afternoon. Thank you so much, Dr. Quinn. That was excellent. I have a question, just wondering about what is the latest recommendation for women who are HIV positive for delivery. Is a C-section always recommended, or does it depend on the viral load at the time of delivery?
No, so C-section is an option, but it is not routinely recommended unless there's been increased duration of rupture of membranes. Then it would be recommended. What is recommended for all pregnant women is antiretroviral therapy during their pregnancy. At time of delivery, they're continued, and then the baby is prophylaxed. C-section does not need to be performed, and vaginal delivery is what is primarily recommended. In Europe, they tend to use the C-section a little bit more frequently from some studies on duration of rupture of membranes, but that's Europe. In the U.S., we don't have any set guidelines other than prolonged duration of membranes, and I think it's greater than 3 hours. I'm not entirely sure what that duration, but that's listed in the guidelines.
Thank you so much.
You're welcome. Thank you. Any other questions from the group?
I'm showing no phone questions.
Okay. We have one here.
Hi, I'm Jenny Bowen. I'm a new EIS officer in the Division of STD Prevention. I was really surprised at how, I say, poor the rollout has been for male circumcision. Can you tell me if the bottleneck is with training and providers, or is the bottleneck with people showing up at the door wanting circumcision?
Great question.
That's the first part of my question, and there's a little bit of a follow-up.
Let me answer that, because it is clearly uptake by the individuals. So training's rolled out very nicely, and in fact, there's now devices that you can use that make it even simpler, that a non-clinician can apply these. The uptake has been slow, and we've been doing some studies, and Maria Waywar has a particular grant trying to look at the uptake to enhance it. And so I'll give you an example. They had an event where they had a soccer or football event in Uganda, and like 1,000 men showed up. They're very excited about football and so forth. This is, that gets them going. And they set up the circumcision there, and the education, counseling, and they're there for a sporting event, and they actually educated them about it and offered it, and they actually got a huge increase in uptake. I think it's when you go to the village or the community and say, we're going to do circumcision in the next week, people are saying, I work. I don't want to walk around with a cut penis, and I don't have the time for that. So it's the uptake, and if you provide the right incentive at the right time, you can make a difference. So follow up.
So and Maria, to be fair, was my master's advisor 5 years ago. She'd be embarrassed at how I've not followed up on her work in the meantime. But I guess
she's a master at this.
My question is then, maybe we need to be taking a longer-term perspective at this, and maybe we don't need to have an elimination by 2023 campaign as much as we really need to be taking all that money and shoving it into infant circumcision instead. It would postpone you wouldn't reap benefits for a very long time, but perhaps the benefits would be 4 times greater than what you could reap today. I'm just wondering what your thoughts were on that in terms of, have the modelers looked at postponing the circumcision, and what would the benefits be?
Well, we do need an immediate benefit. When we have an intervention that we know works, if we were to ignore it, that would fly in the face of logic. I mean, we basically have something that works. It's not that expensive. It's $45 in the adults. We're not talking a lot of money for a single one-time intervention. However, your point about would it be more cost-effective to save more money, so to speak, to do it in neonates, the answer is yes. But the effect wouldn't be seen for 18 years. So I think you need to do both. Focus on the adults, get policy to change neonatal circumcision, get the word out there this works. The American Academy of Pediatrics has now changed their guidelines and have said neonatal male circumcision provides public health benefits. It is a decision by the parents that are to be made, but they should be informed of the public health benefit as well, and individual benefit, as well as the potential risk. Give a balanced approach. Their guidelines didn't say that before. So in the last year, we've seen a major change even in this country. I would like to see, I'm going to put in my word, I'll probably get thrown out of the CDC, but CDC set up a policy paper on this that was very supportive, and it's not seen the public light of day. I would like to see that happen sometime soon, and that it shouldn't remain buried here in the bowels of CDC. That's my political statement. And Tom Frieden may be coming after me as a result. Great. Thank you.
Thank you, operator.
This does conclude today's conference call. Thank you for your participation. You may disconnect at this time.
Okay, thank you. Bye.